let's talk about the difference between a sunspot and melasma.
Okay.
Because some people can have large sunspots. And we talk about hyperpigmentation in different areas of the body. And then we talk about melasma versus solar elastosis, which is just a fancy name for, I guess, your aging skin, right?
Wisdom and maturity spots.
Wisdom and maturity spots, sunspots.
Yes.
And freckles. And sometimes they all get lumped
together.
And
then a lot of them you've had most of your whole life. A lot of them go along with genetics. A lot of them come with age and UV exposure. So it takes a dermatologist to be able to look at them specifically and give you the correct diagnosis.
I'm going to ask a question just because I do some basic skin checks, mostly related to skin cancer, but not a lot of full body skin checks. Tell me how you would like a patient to come to your office to see you for a regular skin check. Like, you know, I see all these women coming like dolled up with all their makeup on, and they have very difficult and beautiful like clothes that they've worn all day at work. So like if you were telling somebody to come to get checked out for their full body skin check or their face for you to diagnose them with a problem like melasma versus other skin conditions, like ideally, what would you tell your patient?
You know, you don't have to dress up to come see your dermatologist. We have seen it all. We usually even ask you to get undressed and put on this gown so we can check everything to make sure there's not any areas of concern, because a lot of people live alone. They can't see their back. They've never had a skin check, but a lot of women do come in mid-work, after work, and they come in with a full face of makeup. I try and keep gentle cleansing cloths by Cetaphil in my office so these women can wipe their faces off so I can get a good look at areas, especially if they have areas of concern. A lot of people come in and they're like, I have a mark on my nail, but they have gel polish on and I have no way of getting that off. So that's making them have to get another appointment to go get their polish off so I can actually get a good look at these areas. So you don't have to impress us. We are there to look at the raw skin, just like we're giving you the raw truth. But you don't have to look like a homeless person either. You know, I'm not telling you just to crawl out of bed and roll up. If you need to come through in work hours and you have makeup on and you're dressed to the nines, that is okay. But I will probably make you remove a little bit of makeup so I can see your skin.
Yeah, so bring your makeup bag
if
it's important for you to go back to work and redo that. I think that's a great tip because we don't think about these things, especially the nails, right? Even for me, who's not a like board certified dermatologist, but again, I see a lot of skin cancer patients and they'll come to me after an excision and be like, hey doc, can you look at this, right? So I'll take a look at it. I routinely look at nails for many different reasons, right? Just a healthy nail bed for fungal just screening,
psoriasis,
right? For psoriasis, eczema, and we can have just a streak. I got a lot of referrals for nail biopsies for what is probably just a normal, so you can get freckles in your nail bed, right? Melanchia, exactly. So it's important to be able to take a look at it, and sometimes you can get skin cancers of the nail bed as well. So being able to see nails is critically important. It is
very important.
And I always try to get them to take their socks off too.
I usually pull their socks off and I give them the story of, you know, Bob Marley had melanoma between his toe. I just like to check between your toes, but I put their socks back on. I've learned if you didn't like feet, you never go into dermatology. I was always told that. So I'm comfortable with removing your socks if you want to keep them on for the time being. But yeah, I definitely like to look between people's toes, their feet. People don't get down there enough to look at their feet. Some of them never even knew they had a mole on the bottom of their foot when I pointed out.
And I know one of our focuses was melasma today, but I wanted to talk to you about white spots. So I see that a lot as well, right? Yes. People who have areas that never tan.
Idiopathic guttate hypomelanosis. Fancy term for white freckles.
Right. So how concerned about those are you?
You don't necessarily have to be concerned about them. You get dark freckles from the sun. You get light freckles from the sun. Those areas of skin are just damaged from so many years of UV exposure that there's no melanin producing in those areas. So I tell my patients, if you really want to cover them up, you're going to have to put a self-tanner on top of them because they will never tan because there's no melanin to tan in those parts. But very common. See it on shins, arms, especially my women.
I have pityria rosacea. So that's another thing that's kind of makes a mark on our skin that sometimes people might be a little eerie about. I see it on some Facebook posts at times. Oh my God, like there's this like area that's totally different than the rest of my skin. And some people are like worried about vitiligo, right? So there's lots of different characteristics of skin. So there's a spectrum, right?
There is a spectrum.
So talk to me a little bit. I know we probably weren't going to talk about this, but I'm going to take it there. Talk to me a little bit about vitiligo and some of the options and how you diagnose that as opposed to like dark spots.
So vitiligo is kind of where your body starts attacking in the melanin in the skin for some reason. Could be an autoimmune disorder, could be genetics, could be sun exposure, could be a slew of things. But it starts attacking the melanin in the skin due to the inflammation, and those patches can get larger. I see it anywhere on the body: face, buttock, groin, feet, even our private parts. Okay. So in general, people come in, you kind of take a look at them. There's two different types. You have one-sided vitiligo, you have two-sided vitiligo. So it's called segmental and non-segmental vitiligo. But definitely can be anywhere on the body. Once I diagnose somebody with this, we look at more anti-inflammatory properties of medications like topical corticosteroids. So I usually have them do a trial of that for 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off. I also add in something called a topical calcineurin inhibitor, which would be like tacrolimus, that takes the inflammation down in the skin to try and get some of that color back. And they use that on their 2 weeks off of their steroids. So I always have something constantly going on the skin, including their sunscreen, because again, we don't want to cause any more damage in those areas because that skin's more apt to burn because it has no protection from the melanin. And usually it can cause enough inflammation to calm down to allow some of the pigment to come back. Now, vitiligo has no cure as well. It is a lifelong thing. Usually when you stop some of the medications, it's going to tend to come back, and sometimes it can come back worse. I have a patient that I inherited from somebody that had retired, and she's been working with her for years, and she finally rebounded, and none of the medicines were working anymore. So we have her on a new medication on the market called Opsilura, and that is a non-steroid that can go on every single day. But it takes about a year to see full change in the skin.
That's really interesting that it takes a whole year.
Yeah, most of those patients can get about 80% of their color back with a year, just Opsilura.
Do you do extract?
So I don't personally do extract. I usually refer to one of my other colleagues. I usually do light box for eczema, so we all have our little niche. But I do refer extract for smaller areas, especially around the neck, face, scalp, stuff like that.
I've never even seen it, but I know a lot of people doing it. So I was like, oh, maybe I'll ask, Andy a little bit about it. What are kind of myths around these pigmented lesions in the skin that you would like people to know?
Just because it's been there your whole life doesn't mean it's not something, because moles can always change. So I'm like, you can have something changing now from 30 years ago. Okay. I had a brand new mole removed a month ago that popped up 3 months ago, and it was abnormal. And I guarantee it's from my days in the tanning bed back from when I was a teen. So just because you have new moles does not mean there's something on the other end of the spectrum. Okay. New moles, new ways, raised, rough places could be an age spot, but anything new over 30, I usually recommend getting checked out by somebody that can look at it a little more in depth to make sure it is not something.
Is melasma something that is age related?
No, it has no age appropriate with it, because again, it could be hormonal. So I've seen it as early as teens. I've seen it as old as senior age. It definitely just depends on, like I said, your hormones, your UV exposure, oral birth control, if you're going to get it or not.
So if you have something that looks like melasma, somebody has told you it's melasma, but it's changing, it's time to go back.
It's time to go back. It's time to get it looked at, because it may be something else on top of that. You can get those age spots that we were talking about earlier on your face. They're called solar lentigos or solar lentigines, and people get a lot of those sun freckles. They tend to come up in more circular leaf-like patterns on the face compared to patches, where you're getting those blue-gray patches from melasma, and you can actually get an early melanoma in those called a lentigo maligna. So I usually tell people, even if you have those on your face, getting that yearly skin check so we can kind of look at it with our dermatoscope to make sure nothing internal is changing, or the they call it colors and chaos. You're looking for structures and colors in these moles to see if they're changing, to make sure it doesn't need a biopsy.